right, we'll go ahead and get started. Once again, for those of you just joining us, my name is Leanne Foster, and I am with the Provider Outreach and Education team here at WPS, and I want to thank you for joining us today, and I hope you are doing well. So today, I do want to welcome you to our last in our evaluation and management series of choosing your level of service. This is the Pier MDM perspectives, and we are going to be focusing on clarifying the risk element. Now, this is a two-part series. Some of you have maybe been following along with our various series. In April, Ashley and I kicked off our level of service series and have been doing a breakdown further over the last couple of months. In April, we talked about using time, and in May, we started breaking down MDM. And we did an overview of medical decision-making, which we'll talk about a little bit today because I do not know who on the call has actually attended that, but we'll just do a really quick overview. So as I said, today we are focusing on providing a better understanding of the risk element when you're using MDM to select the appropriate level of service when you are reporting your E&M codes and billing Medicare. So I've also asked Ashley to place some links into the chat to our previous sessions in case you missed that and would like to see any of those or go through those. Also, as I mentioned, this is a two-part series, and if you've been following along today, we're really going to focus on building your knowledge for the risk element. And tomorrow, Ashley will be hosting an interactive Q&A activity talking about denials and rejections, but also letting you apply your knowledge from today. Registration for that is still open. It will be open through the end of the day today. So if you want to register for that, I do encourage you to do that. So how are we going to help you better understand risk? So our focus today is going to be a little bit of a medical decision-making overview, again, making sure we're level set. We are going to talk about the risk element and the level overview. We're going to go through some of those pre-submitted questions that we received as they relate to those elements and those levels. And one of the questions that we received multiple times was seeing documentation of things. We are going to go through some documentation examples for those risk elements to show you how we are seeing things come in. That's also going to include a little bit on prescription drug management. That is definitely a hot topic, and we'll get to that a little bit later on. We're also going to provide you in the resource section with some additional resources that can help you when you're using risk to select your level of risk and using MDM to select your level of service. So as I said, we're going to start with a brief MDM overview. Pardon me. So first and foremost, and if you've attended any of my sessions, you hear me say this all the time, but when the first and foremost determination of whether or not a service is reimbursable is going to be medical necessity. Medical necessity is really what determines that coverage, and this is per the Social Security Act, which I have included a link here. But medical necessity means that the service must be reasonable, medically necessary, and not something that is statutorily excluded from Medicare coverage. How do we make this determination? It's all going to come from that documentation. You're going to hear me talk about that a lot today. It's all based on what that documentation supports. If it's not documented, when a claim is reviewed, we cannot make assumptions. If it's not documented, essentially it didn't happen. Doesn't mean that it didn't, but it means that our reviewers, when we're reviewing those claims, do not know that it happened. Certainly do not want novels. We want to keep documentation as simple as possible, but there are some key pieces that will support this, and we'll talk about that a little bit further on. When choosing your level of service, as you may or probably are aware, you generally have the option between choosing your service based off of time or medical decision-making, that MDM. It doesn't have to be one or the other 100% of the time. It can vary by organization, business office. It can vary by patient, and you may use time for the same patient on one encounter and MDM the next encounter. It all depends on what is happening in that encounter, and you want to make sure that you're not leaving any money on the table. There are times where The MDM may be at a low level, but it was an extra amount of time, which represents extra work. Time might be your best bet. It can also flip the other way. It might have been a short visit, but there was a lot of cognitive load. There was a high level of medical decision-making involved, and MDM makes the most sense. Like I said, you can make the choice for most services and choosing what's appropriate. There are a couple of exceptions. So for emergency department and critical care services, it is defined which you can use. So for emergency department, it's MDM only. You cannot use time here. When we're talking about emergency department, we're talking about codes 99281 through 285. And as you've maybe heard me say before, it is based on what's happening in that type of environment. Their providers are likely seeing patients multiple times. They're likely working with multiple patients, and it's really hard to track the time. And so MDM is the exception as far as having a choice. You do have to use the MDM is the only way to choose that level of care. Critical care services, you do have to use time. That is because if you are providing those critical care services, it's already factored in that this is a high level of MDM. So here we're really just looking at the time that was spent on that. And I have listed those codes, that 99291 and the 99292. We're not getting into emergency department and critical care today. Those are just high-level exceptions. We do, however, have some recordings on our YouTube channel if you'd like to dig deeper into those. So the elements of MDM, we're focusing on risk today, but the elements of MDM are our problem, which is going to be the number of problems and the complexity of those problems that are being addressed in that encounter that day. It's not going to be the laundry list of everything that's going on with the patient. If it's not addressed in that encounter, it's not going to count towards MDM for that visit. We also look at the data, which is going to be the amount of data that is reviewed and the complexity of that data to determine your level of data. And risk, this is today's focus. So with risk, what we're looking at is going to be the risk of complications, morbidity, or mortality to that patient of their conditions, but also their care plan, the treatment plan, what's happening with that patient. So it's going to be unique per encounter. It's going to be unique per patient. It's going to need to be supported in documentation. You'll hear me say this a lot today. It could be a risk-benefit analysis from your practitioner. It could also be the risk of the patient's choice. Maybe there was a plan of care that was considered, but the patient chose not to, and we do have an example of that. That'll count as risk. So the biller, the coder, probably not necessarily going to be able to choose that without specific information from the practitioner. We did get a question asking if the provider needs to document the level of risk in that medical record, and the answer is they do need to make it clear what their medical assessment of that patient's risks are. And we'll talk about that a little bit more. But that documentation is their proof of thought as far as what went into choosing that level of service, what level of problem, what level of data was used, and what is that patient's risk. So let's take a deeper dive into risk. You're going to have typically 4 levels: low risk, straightforward risk, moderate risk, and high risk. So I want to start with just that definition. And we've talked about it a little bit already, but we're talking about the risk of complications, morbidity, or mortality, and these can be and/ors, to that patient from diagnostic, diagnostic testing. Are there procedures? Are there treatment decisions that are being made as part of their care plan? What are the risks for that? It's all going to be based on the problems that are being addressed in the patient management decisions. It goes back to that proof of thought. You'll hear me say that a lot. They have to look at the complications that could typically happen, and then what comorbidities that patient may have that could increase or lessen those risks for that patient. And this is one thing I do want to call out, and we'll talk about it a little bit later. It's also not just medical risks. It could actually be economic and social conditions that are specific to that patient. So, for example, you've got a patient that was diagnosed with diabetes. Maybe the plan is to give them nutrition information. However, that patient is telling you that they cannot get to a grocery store with fresh fruits and vegetables. Maybe they live in a food desert and they can only get convenience foods. Well, that's going to pose a particular risk. That's going to account for some additional work from that practitioner as you figure out the changes or the risk of them not being able to follow that nutrition plan. That's a social condition risk. That's something outside of medical, but that does constitute something that should be considered for a risk. Another situation that can happen is you order a medication that the patient says that they cannot afford to pay for. So again, that's going to pose a risk to that patient's healthcare outcomes and something that does need to be assessed for that patient. So you're thinking about the patient's overall scenario. I do want to talk about morbidity just a little bit more. Now, mortality is pretty easy to define, life or death, right? So threat to the patient's life. Morbidity is a little bit different. And we get questions on this, so I want to make sure that I'm clarifying morbidity here. It's more about long-lasting issues from the treatment of the decisions that are being made in that encounter. So it's about an illness or an impairment that the patient is at risk for, either if left untreated, if treated, how it's treated. What is the risk of further illness or impairment? It's also going to be something that is expected to have a substantial duration. So this is not necessarily going to be something that's in a predetermined timeline. It doesn't maybe have a clear path. It may be something that's transient. It's going to be something that's not necessarily short term. There's a real risk of them experiencing this risk or this illness or impairment for a substantial amount of time. It's also something that will result in limited function and may result in the impairment of the patient's quality of life. Okay, and risk of death does come into this as well, but there are things that come into play prior to that. We did have a couple of questions again about consideration for diagnostic testing and treatment or a procedure and its impact on risk. And I want to address that here because that risk is the probability and consequence of an event. So it does include considering their morbidity from that choice, that decision that's being made, and that includes them foregoing that. And you'll hear me say that quite a bit. The one thing though is the medical judgment does need to be documented and support what they're thinking about. So again, when we're looking at risk, what is the risk of the patient management? What are those decisions being made? And what is the provider assessed risk? We did get a few questions again about does the provider need to document the risk in the medical record? And the answer is going to continue to be yes. They have to assess the risk. They can use common language, but what's the probability of the risks? What's the risk or consequence of those decisions that are being made? Whether that is to proceed or to forego that treatment. Again, what are the risks from those problems that are being addressed? And it may not be clear. Providers can use common language, meaning those levels, the straightforward, the low, moderate, and high. They don't have to, they can, but they do have to document that risk. And sometimes that may require a query to that provider about that risk if it is unclear. And that's something you'll hear me say a couple of times today is you want to work with your providers to help them understand the importance of documenting that risk. And we'll show you some documentation, some ways to do that. So I want to go into the levels. This is where we'll get into those examples. So the first example is going to be straightforward and low, and I'm kind of combining these. We'll start with straightforward, but straightforward and low are similar in that the practitioner has identified a minimal or low risk to the patient from the treatment plan or risks from their patient. An example of something with a straightforward or low risk, an otherwise healthy person that has a sinus infection. That's probably going to be a low straightforward risk. But again, it depends on the patient. Conversely, if they have comorbidities that are being considered, if they have COPD, that's going to likely change their risk factor. So straightforward and low is minimal or no risk. Low risk, same thing. It's just there's a little bit more than no risk, so to speak, but there are maybe some minor risks from additional diagnostic testing, or an X-ray, depending on the X-ray. We received some questions about CT scans. It kind of depends on that contrast. And again, the patient's comorbidities. Contrast may not be a high risk for one individual, but it may be for another that says it has an allergy to that. So what that looks like, here we have an example of what a straightforward or low risk documentation might look like. So in this example, this is documentation for an encounter that is a 6-month follow-up, and they're getting an echocardiogram. Okay, they're just checking up. They do not have any new complaints or problems that they're addressing. And I'm showing you the pieces that we want to focus on, not the entire medical record. It was definitely multiple pages, but their chief complaint, the reason for that encounter is that 6-month follow-up for that echocardiogram. Without new complaints, they didn't do any other procedures. They didn't need to plan for any additional interventions. They did not manage any of their prescriptions in this. There was a list of prescriptions in the documentation, but they did not manage those at all. You'll hear me say this throughout, but prescription management is not as simple as a review of the medications if that medication was not managed. And in this piece of documentation, they did not manage any of their prescriptions. They didn't change anything. They didn't assess the effectiveness of anything. Their plan was, and as you can see here in the assessment and plan section, is that they're going to return in 6 months for that additional testing to have another echocardiogram. So here we're going to move into moderate risk. I mentioned that a little bit, but one of the questions that we get often, or questions we get often, are about the examples that the AMA has put into the CPT. Those are examples only. They are not absolutes and they are not automatics. But the types of things that will bump that could bump that risk up to moderate could be that decision for a minor surgery. Whether a surgery is minor or major is based on that specific patient. It is not based on the global period that Medicare has assessed. Certain procedures do have higher risks, but you have to consider the patient as well as that procedure. The other piece that does bump up that risk potentially to moderate is going to be prescription drug management. Now, one thing that I do want to make you all aware of is we have been working with our medical review team to create a resource for prescription drug management. We do anticipate that to be posted to our website in the very near future. It's actually going through its paces now to get published. That hopefully will help outline prescription drug management a little bit more clearly. It's also going to have a companion resource that is going to include some scenarios and whether or not they would be classified as prescription drug management. But the key here is going to be that assessment of risk to the patient. Simply reviewing a medication list and not doing something to it, whether that's renewing it, whether that's changing the dose, maybe you're increasing the dose, maybe you're decreasing the dose, maybe you're stopping a medication altogether. But if you're not medically managing that, it's not a blanket statement where review their medication list. That's not going to be something that's going to be continued or assessed as prescription drug management. It's just a review. There's no management of it. It does need to be documented what the risk to the patient is and what was done. So you want to make sure that that information is in that documentation. The other thing I do want to call out here, the AMA does have in the CPT that this could potentially include prescription and over-the-counter medication, but again, based on patient-specific risk factors, because generally with an over-the-counter, it's not going to be go home and take an ibuprofen. It could be the dose is higher. It could be the patient is on some other medications, but this needs to be more closely monitored. They could have a condition that requires closer monitoring. So those are the things that you want to make sure are documented when you're considering that prescription drug management. Also for moderate, we have social determinants of health. As I mentioned that before, you have a patient who's been diagnosed with diabetes and they may have social and economic conditions or situations going on that are going to impact their health and their ability to better manage their health. You want to make sure you're considering that. That absolutely can be considered and can bump up that risk, but you have to show what that limitation is going to be. You have to connect the risks to what's going on with that patient and their care plan. So make sure that that information is documented. That's really going to help you identify that as a moderate risk. It's going to support it on a review. So this is an example of a moderate risk. So in this situation, we have a patient that came in, they're having elbow pain, they're having an x-ray on their elbow. They fell and they had some confusion for a period of time after they fell. And there was a wound present. The provider did document, and you'll see in that green box on the image that's shown, the provider did assess that the patient's heart rate was fluctuating while they were suturing the patient. So they did notice or did document that bradycardia, and the provider would like to monitor that. So they did discuss placing a monitor so that they can keep track of that. The patient was agreeable. And that bradycardia is something that is posing that risk. It is documented here what occurred, okay? And that bradycardia, again, is going to be at that risk. They're not necessarily using that straightforward low, moderate, or high risk language, but they are monitoring what their risk is. So coming back to prescription drug management, as I promised, we wanted to provide you with an instruction with an example of prescription drug management. Again, it is an example of moderate risk and it is not automatic. Here on the screen, you do have a screenshot just showing that. Again, these are examples. They are not an automatic. It does have to include that review and management. So they're evaluating even the need for the medication. They're maybe initiating a new medication. They could be deciding not to start a medication. We did get a question about considering a medication, but not initiating it, moving forward with it. That can count as prescription drug management, but it has to be documented, and you'd want to support why they chose not to move forward with it. Maybe it puts the patient at high risk. Maybe the patient was not open to starting that medication. There's a lot of things that could happen there, but you want to make sure that that's going to be adjusted. Maybe the medication is being monitored for its ineffectiveness, and you're deciding to renew a prescription at the same dosage. It is working, they are tolerating it well, and you are renewing it. You're showing that assessment. Now, if you're renewing it and it was just a review, and typically a renewal is going to fall into that category, but we need to be able to see that it was assessed, that that prescription was managed, and this is that outcome. I mentioned discontinuing the medication. It can also be evaluating the patient for risk factors. Again, it comes back to that consideration of a drug. Is there a contraindication? Does that need to be managed? But we're going to we're going to initiate the drug anyway. Those are the things that you want to look at. When you're documenting your prescription drug management, broad statements are not generally going to support the risk level of prescription drug management. We have to have that documentation tell the entire story. Again, that proof of thought from the provider about that risk to the patient. So here we have an example of the documentation from something that does qualify as prescription drug management. So this is going to show you their medication list. That medication list was reviewed, but if you look in their assessment and their plan, the provider is saying that they were on a beta blocker. That beta blocker was lowering their pulmonary function. And because of that assessment, which is documented, again, as you can see fairly simply, but it was documented, they have decided to discontinue that beta blocker. This is something that was reviewed and managed. So this is an example of that. A couple of pre-submitted questions that I do want to address here. The first question was, is there any qualifying risk associated with recommending the use of over-the-counter drug therapy for symptom management? The example that was given was Afrin for recurring nosebleeds, and how that relates to MDM. So like I said, the AMA has included in the CPT that RX management can include the over-the-counter medication. However, that documentation must support that thought process and the risks. So if it's a recurring nosebleed and they're managing that over-the-counter medication with relationship to those nosebleeds, they do need to show that. The other question that we did get related to this is, can treatment with a high-risk drug on its own put you in the highest risk category, or does the provider need to specify the risk? This is a fantastic question. The answer is possibly. So it depends. So for instance, certain drug classes, think anticoagulants, chemotherapy, immunosuppressants, they're generally universally recognized as high risk, but the documentation still needs to support it. Just the drug itself being documented doesn't necessarily support the risk. It's there, but the provider still needs to document the risk to that specific patient based on their comorbidities and what's going on with them. So next we are moving into high risk. So for high risk, the examples of what falls into this category include drug therapy that's going to require intensive toxicity monitoring. Here you're measuring the toxicity of the drug, not its efficacy. So it's not just about how effective it is, but it's that toxicity level. And so an example would be a chemotherapy drug. you'd be performing testing on that patient to determine if there are any adverse effects. So how are they tolerating that? You're not performing again just for the efficacy to see if it's working, but you're also testing for those adverse effects. You're looking for, is it increasing the risk of mortality or morbidity? What is it doing to that patient? And it does need to be documented. Again, as I just mentioned, it being a chemotherapy drug doesn't automatically bump it to risk. We do need to also know the patient-specific risk factors. The next example that's given in there is going to be the decision for surgery. So major surgery, again, it's not based on the global period determined by Medicare, and that's outlined in the CPT. You have to look at those surgeries. We're also looking at whether the surgery is going to be an elective or a major surgery. That can also bump up that list. If it's elective, not saying there aren't inherent risks for surgeries, but you do need to address the situation, the patient situation, comorbidities, what's going on with them has to be assessed and documented to support that. So again, back to where I was going with an elective surgery, that's typically planned. That's something, there's certainly going to be risks, but then there's an emergency surgery, and that's going to be something that where you're determining that patient needs this surgery now. That's going to be a different level of risk than one that maybe is elective. But again, the providers are the ones that are going to be determining that risk. Next would be the decision for escalation of care or that decision for hospitalization. Again, going to have to document that. We do have an example here that we'll show you in a minute, but the documentation needs to support that. And with that decision for surgery, we'll go into that, or excuse me, hospitalization, we'll go into that in a little bit more detail here. But I do have a couple of questions that were asked that I want to address here as well. We received this one several times, asking about those inherent risks of a procedure, and if the inherent risks of a procedure alone can qualify it as high risk. So again, each procedure is going to carry inherent risks that are going to be specific to that procedure itself. We're not questioning that. However, those alone are not what's going to be used for the risk. A patient is going to have specific risk factors that will either increase or decrease those inherent risks from that procedure. So that is what we're looking for in that documentation for that specific patient, for that specific procedure. What is their patient-specific risk level? It's not going to be dictated by the procedure itself. Certainly, certain procedures are going to elevate that risk, but we still need to look at that patient. Another question that we got was asking, are fractures and ligament tears considered high risk since they pose a risk to bodily function and the patient may not be able to walk or use their arm? So fractures and ligament tears could be considered high risk because of that risk of long-term mobility or impairment, that loss of use, that loss of function to that affected area. However, as I've stated, we still need to have the providers document that patient-specific level of risk based on how severe the tear is, how severe the function is limited. So it's not going to be automatic based on a diagnosis of a fracture or a ligament tear. Provider still needs to provide that supporting documentation. So here we do have an example, and this is one that did come through a review and was allowed at high risk. So what we have here is an example of a patient that presented to the ER multiple times. They presented 4 times with severe nosebleeds. Basically, they're complaining of a nosebleed that's lasted for 6 days in duration. That is quite a nosebleed. And they're also a patient that's on blood thinner. So that's going to be exacerbating their condition. That's certainly going to be a risk factor. So what happened here is the provider did make a decision for hospitalization. They offered hospitalization because of those comorbidities, because of the severity of the nosebleed, the comorbidity of them being on blood thinners. They're not able to get it under control. That patient has gone to the ER multiple times. However, the patient declined on the initial offer of that hospitalization. The patient declining doesn't lower the risk level. They document that the patient declined until I believe it was the fourth visit. Looking into the other parts of the documentation, I believe on the fourth visit they accepted the hospitalization just for observation, because again, those blood thinners are making that nosebleed quite risky. So what you see in the documentation, the way this organization has this facility has theirs laid out, they have a section for medical decision making, and they are talking about how they offered that hospitalization or that observational stay for the patient. They do have that background of the multiple episodes. They do actually here they have a risk section where they're talking about having managed over-the-counter drugs, and that they made that decision regarding hospitalizations. Now, I want to be clear, this looks a little bit, this is this organization's template. This is not a template from CMS or a MAC. CMS and the MACs do not have templates for documentation, and they do not have standard verbiage suggestions for documentation. And they will not, because again, the documentation is going to be based on each patient and each patient's scenario, and risk factors are going to be different. This is just an example of how they're doing that. And then in the bottom, they are showing a little bit more information about the medical decision-making that was made and those problems addressed. But this is one example of how high risk could be outlined or documented. So going a little bit further into that decision for hospitalization, it could be hospitalization or escalation. So it's not just going into the hospital for the first time, it could be escalation of care, but it does need to be documented. In our example, that decision was made by the ED doctor, but the patient declined. As I said, that does not change that decision was made. It's just that they chose to forego that. So things to consider is, or things that we're also going to need in the documentation, who's making that decision? We get this question in other sessions. The provider refers the patient to the ER. The question, or what we're going to need to see for a provider in the office to account for that risk level, did they make the decision for hospitalization, or did they refer the patient for further assessment? If they're referring the patient to the emergency department for further assessment, that's not necessarily a decision for hospitalization. Typically, we do see that often made by the emergency room physician or provider or another provider in the hospital. That is not always the case, though. So just make sure that it's clear who's made that decision for the actual hospitalization. We want to make sure that that is supported. You also want to make sure that you're supporting why that decision is being made. It's not going to be assumed. So what's going on with the patient? Why do they need that? For instance, the one we just looked at, they have that nosebleed that's lasted for 6 days. They've come into the emergency department 4 times. That supports why that decision is being made, because they keep having to come in. There is that risk. The other thing I want to call out here is that a recent hospitalization doesn't automatically make a patient high risk. You've got to show in the documentation, maybe they've been discharged from the hospital recently, they're still high risk because. So we would just need to have that clearly laid out in the documentation. We did receive a question related to this as well. So we had a question asked if there is a need to move a patient from an acute inpatient rehab, and the decision was made that the patient needs to continue hospitalization to be safe before returning home. So they're going from an acute acute ward to an inpatient hospitalization. The question is asking, is this considered high risk? So the move from acute to that inpatient rehab itself is not automatically high risk. Again, it's based on the information that was provided. The patient was ready to leave the acute unit, but they weren't ready to go home safely. Risk depends on why weren't they ready to go home safely. Okay. So was it that they were at high risk if they went home? Or is it that they maybe didn't have a caregiver at home? Could still make them high risk, but we need to know in the documentation why they're being considered high risk. It's not automatic. As I mentioned, hang on, that didn't move. There we go. Wanted to talk about, again, the decision for surgery. We already talked about this a little bit, but I did want to pull this out on its own. That decision for surgery that risk can apply for a major or a minor surgery. Okay, again, based on those patient-specific risks, they're given as examples in the CPT, and they're not based on that procedure class. They're not based on what that global period is. I did mention this. You need to look at if the procedure is elective or emergent. That can certainly increase or decrease the risk. There are going to be those procedural risk factors, but it is not based on that CPT code alone. Now, there are evidence-based calculators that some organizations use. Those can be used. Okay, there's nothing that precludes providers or organizations from using those. Those are not something that we're going to advocate for one or the other, but those evidence-based calculators are okay to be used. All right, so we've gone through some documentation examples, but I do want to focus just on documentation requirements. So for risk, we're not looking at anything different than we are for any of our other documentation. Documentation is going to need to support the medical necessity of the services that are being provided to the patient. What's going on with the patient? Why do they need your services today? The elements in that documentation need to be that evaluation. So you're evaluating their problem, their condition, what's going on. There does need to be a history. You do need to assess that current situation, and you do need to show what that care plan is, what tests are going to be ordered, are there prescriptions that are going to be initiated, is there a level of care change, do they need interventions, what are those? And then also the services provided in that encounter. Now, we do get asked about owning notes from a previous encounter. That is not something that CMS prohibits. It is something that you want to use with caution because you need to make sure that that's all being adjusted so that it accurately reflects the current encounter. Completely understand it from an efficiency standpoint, but you've got to make sure that it's accurately reflecting what's happening in that encounter. If something was checked on a particular day in a previous encounter, you clone it over, you checked it in this encounter, but you didn't make that adjustment, showing that you checked, say, an A1C level, or you checked function of something, it's not accurately reflecting that encounter. So you just have to use that with caution. Now, risk, I have mentioned a couple of times that they can use common language. And we did get a question that said, can a provider type out literally, patient is at moderate, or whether it's high or low or straightforward risk of complication and or morbidity or mortality? Would this account for that column? The answer is they can use that language. We don't often see that. And I think I saw a question come in the chat looking for an example where they did. We did have one that was using it. We don't find that gets used a lot. That is actually something that CMS wants the providers to do. However, it's not as simple as just listing that risk. The documentation also has to support it. So if they say the patient is at moderate risk and there's nothing to support that level of risk, on a review, that's going to get questioned. So you want to make sure that if they're using that plain language, they are also showing their thought process in that documentation. The other question that we got relates to my last bullet here. And the question is, coders are not clinicians. Therefore, how do we decipher the risk when it's not clearly documented? It's an excellent question, and it definitely puts the coders in a challenging situation because you're not clinicians and you're trying to code these appropriately to the highest level of specificity. Yeah. Being the most specific. Sorry, I can't say that word today. But you can query the provider. You may have to ask the provider. You can't lead them to a particular level, but you could ask them for clarification. If they're changing that documentation, they'll have to do those attestations to show why that documentation changed. But you can query those providers. And this is something that is going to be a challenge. It is something that organizations do need to work with their providers on to be as specific as possible. Again, without writing a novel, we're not looking to overcomplicate documentation, but it has to be clear. And what we do see is oftentimes for efficiency, organizations looking for click boxes that have standard canned language. That's not necessarily inherently wrong, but it has to also accurately reflect what happened with the patient and be specific enough. So typically, it's not going to be a best practice. It's not something that's prohibited, but it has to be accurate. So what we're expecting out of that, with all of that in mind, that documentation has to be the proof of thought for MDM in general, even beyond risk. It has to show the problems that were addressed in that encounter. As I mentioned earlier, it's not going to necessarily be the entire list of everything going on with that patient all the time. It maybe all of that is being addressed in that encounter, but it is going to have to be what's addressed in that encounter. If they have 15 different things going on, but you're only addressing one of those, that's the only problem that's going to account for that encounter. Data analyzed, so you have to be clear what data is being used to make the medical decisions in that encounter. Risk to the patient, which we've focused on today, is what are the risks of the medical decisions and care plan choices being made for that patient in that encounter. Again, a risk is not going to be as clear cut as certain diagnoses, certain drugs, certain procedures are always this risk level. Certainly those can impact the risk, but then the providers also have to look at the patient's comorbidities to see what their risk factors do to increase or decrease the risk of those choices and those decisions that are being made. When we're reviewing this documentation, or if you want to put an audit program in for yourself for documentation to try and improve that clarity for those that are coding the claims, you want to ask yourself, does it evaluate the patient's needs? Can you determine what needs were evaluated? Is that risk documented? And is it clear what that risk level is? And does it make sense compared to what's documented? Is what's billing, does it make sense? So here I have included a few resources. I'm going to get into some questions here in a second, but I did include our Evaluation and Management Services guide. That is the CMS Services guide, their MLN. Also included a link to the Medicare Claims Processing Manual, which is Chapter 10. CMS also has an Evaluation and Management Services page that has a lot of good resources, including some FAQs, which are also included here for you about different scenarios when choosing your level of service. Now, those are going to be not just specific to risk, they're going to be all of MDM, but these will be hopefully useful to you. So that does bring me to the questions and answers section, and I have a couple of pre-submitted questions that were not addressed on the previous slides. So the first one, before I check in with Ashley, is asking, does referring a patient to a specialist due to an issue or condition count towards MDM risk. So for example, the example that was given is the patient has positive colorectal cancer screening and the referral was made for GI. So the referral can count towards risk, but the specific level of risk will vary by patient. So for example, if the referral is for something routine, non-urgent, it's a stable condition, that is likely going to pose a lower risk than say if they're being referred for a procedure for a potential malignancy. Okay, so that could be something that, yep, we're a lot more worried about. That's going to be their risk. But again, you've got to look at that patient. So referral is something that could be considered towards risk, just needs to, the level has to be documented by that provider. All right, actually, I just had that one. So with that, Ashley, I'm going to check in with you. Do we have any questions in the chat?
Hi, Leanne. We do not have any unanswered questions in the chat. I'm just doing a double check. Nope, all questions have been answered.
Okay, so a couple of things as a reminder, those questions that we did receive in the chat, we wanted to make sure we answered all of your questions today. For time, we did answer those in the chat. Those are going to be sent out in a follow-up email. It will be separate from the presentation that I will be sending after this session. You will have 7 days. So if you think of any other questions for 7 days, feel free to send those into our education mailbox, which Ashley has placed in the chat. In the subject line, you want to put the title of today's, which can include the entire title, which she has in the chat, or risk element, or 812 webinar, something that's going to allow our team members that are monitoring that mailbox know that they need to get that to myself and Ashley to get you a response for that. So we will make sure that you get all of those. And like I said, you do have seven days from today to send those in. So with that, we'll go ahead and wrap up. So in a few minutes, you are going to receive an email that's thanking you for attending. There's a couple of things in that. One, that's going to serve as your certificate of achievement. However, in the email that I'm sending out with the presentation from today, that will also serve as your certificate of achievement. We do not issue the CEUs, but both emails that you're going to receive are going to include the contact hours that can be submitted to your accreditation or certification body to count towards those continuing education credits. We're also going to give you an opportunity to provide us with some feedback today. Everything that we do, we want to make sure that we are meeting your needs. So we would absolutely love to hear from you, get some feedback on what we did well, what maybe we could improve. And also there's a comment section that's going to allow you to provide topic suggestions of things that you'd like to see in the future. We do look at all of those, and we do use all of that information to adjust our educational events. So I want to thank you in advance for taking the time to provide that. To access that, you have a couple of different ways. Ashley just put a link in the chat. You're also going to have a link in that email that's coming to you. And then when you leave the session, you will get a pop-up that looks like what you have on your screen. That pop-up isn't malicious, it's not spam. It's just telling you you're leaving the webinar software and you're going into CMS's Qualtrics survey software. So with that, that will end the presentation for today. Again, just a reminder, if you have any questions, you do have 7 days to submit that to our email box. But on behalf of myself, Ashley, and everyone on the Provider Outreach and Education team here at WPS, I'd like to thank you all for attending today. Remember, Ashley does have her interactive Q&A session tomorrow, and registration for that is open until the end of day today. So we hope that you can join us tomorrow. We look forward to seeing you. With that, you may now disconnect. Have a fantastic rest of your day. Thank you all.